Thanks, Prof. Just to let you know, neurology department, all the registrars are here, and Dr. Tucker and Dr. Nightingale as well, who are from the NI Institute. So I'm going to be presenting the case of Neurolisteriosis presented strangely, which we co-managed with Prof. Mendelson and the ID department earlier this year. He's a 49-year-old gentleman who was born mute and deaf, and he's RBD positive since 2017 on first-line treatment with C4 count of 311 and HIV virally suppressed. So he has a strong history of alcohol abuse, and this was confirmed both by him and his family. On the 31st of December, he presented with a 2-day history of acute onset dizziness, nausea, and vomiting, vertigo, and diplopia. Basically, the collateral I got from the family is that he collapsed, and when he woke up, he had this dizziness, this nausea. He described to me that the whole room was basically spinning around him and he could see double. It was horizontal diplopia that persisted for his entire stay while he was in hospital. So he presented to C15 where they noted that the blood pressure was very high. He wasn't a known hypertensive. It was 170 over 110. And they did an urgent CT brain, which I will show now, and admitted to medicine as a hypertensive bleed for workup and rehab. So just to show the images of that CT brain, there it is. So this was the uncontrasted CT brain done because they did think that it was a posterior circulation infarct. You can see hyperdensity in the cerebellum on the left side. That's also a little bit in the medulla extending. Further hypodensities with a bit of hyperdensities as well. And moving up into the brainstem, it was noted to be both in the cerebellum bilaterally as well as in the medulla and the pons. So it was reported by radiology, like I said, as hypertensive hemorrhages in an atypical distribution, and they admitted him as a hypertensive bleed for rehab. So he was admitted on the 1st of January. He was in the medical wards for 4 days. They actually initially assessed him as aphasic because they didn't know that he was mute and deaf, and it was only until the physio phoned the family that they realized this as well. He had NG feeds inside too, and because he was having difficulty swallowing, but when I went to see him, he was drinking water and coughing up and spluttering quite a bit. But while he was in their wards, he had a persistent low-grade temperature, which a blood culture was done. On the 6th of January, they consulted neurology. They wanted input for posterior circulation infarct. When we got to him, we noticed that he had this persistent temperature and antibiotics had not been started yet. The blood culture was still pending and he had been put on secondary stroke prophylaxis. He was also, like I said, it was noted throughout his stay that he had been aphasic, but he actually followed simple commands. And once you started writing to him, he was actually fully orientated and had no evidence of a language problem. So on our examination, we noted that his BP had been persistently high for the entire week that he had been in hospital with systolics of more than 60. He was 160. He was still paroxysmal to touch, and his NGT was in, but he was still taking in oral intake quite a bit. On the CNS exam, we noted that he had meningism, but he was not confused or disorientated. He followed the commands quite well, and he even wrote to me on that examination and assessment that he was reporting horizontal diplopia. He had bilateral horizontal gaze, he wrote nystagmus, and he had significant cerebellar signs bilaterally, so dysmetria, dysdiadocholesia, and he was severely ataxic gait. He had normal tone power and reflexes globally with sensation intact. So our summary was a 49-year-old gentleman born mute and deaf, unknown RVD virally suppressed. He was now presenting with acute onset pancerebellar syndrome secondary to multifocal intracranial hemorrhages. He had also been assessed as a newly diagnosed hypertensive, and he was now having a persistent low-grade temperature. And our differential, we actually didn't think this was very typical for hypertensive bleed or vascular pathology, so it was lower on our differential list, and we thought that most likely it was actually infectious. So in terms of investigations, after about 2 days after I had seen him, the blood culture came back positive for Listeria monocytogenes. The rest of his blood workup was normal and his COVID PCR, his COVID swab was negative. He had had a CTA as part of his workup of a stroke, and this just showed hypoplastic posterior communicating arteries, but no other cerebral cavernous malformations and no other evidence of atherosclerotic disease. We suggested that an MRI brain pre and post contrast be done, and that an LP be done as well. The LP results came back with a slightly elevated protein, 4 polys and 97 lymphocytes, and the stereo PCR came back positive, but that actually only came out about a month after he had been in hospital because it takes some time to come back. So I just wanted to show the images of the MRI brain. So in panel A, that's actually the SWE, and you can just see that there's actually evidence of hemorrhage. That's what you've seen in the cerebellum with the arrows and in the brainstem. The panel B is a T2 flare, which just shows you the hyperintensity, showing that there is actually pathology going on. And then C and D is the pre and post T1 contrast. And you can see that there are enhancing lesions in the cerebellum and the brainstem. They ring enhancing, and they're surrounding edema of those lesions. And if you look at I'll just show the T1 post contrast. You can actually see that these lesions are very extensive. So there they are in the cerebellum, another one over there, and then moving up. He has quite a few that extend into his brainstem, even into his pons and midbrain. So we thought this was quite interesting. Definitely wasn't a stroke. And so our assessment was, in consultation with Ida, we thought this was Neurolisteriosis presenting with multiple intracerebral hemorrhages. He was started on high dose, so that's 3 grams QID intravenous ampicillin for 21 days, which he completed, and he was discharged home with significant improvement in his clinical symptoms. And as far as we know, he is still doing quite well. So I think our discussion regarding this case, why we found it so important and why we would like to discuss it from a neurological perspective, is actually the radiological findings of neurolisteriosis, as well as how they can present and how it can often be a little bit atypical. Listeria is a foodborne pathogen and is responsible for listeriosis, which is, as we all know, severe systemic infection. The 3 main causes or clinical forms that you get are maternal neonatal septicemia and neurolisteriosis, which is what we would just really be discussing. People that are usually predisposed to getting neurolisteriosis, and there are a number of factors that have recently been published, as in 2017, were patients with ongoing cancer, multi-organ failure, decompensated comorbidities, monocytopenia, and also if you have a concomitant bacteremia for neurolisteriosis. And what they proposed is actually, if you're positive in the blood culture, then it's most likely that you have a much higher load of listeria, and therefore more likely to develop neurolisteriosis. It's one of the leading causes of meningitis in Western countries, as well as with HSV and BZV, and it has a very high rate of morbidity and mortality despite antimicrobial therapy. So when we look at neurolisteriosis, it makes up about 5 to 10% of all cases of listeria. There's a number of ways that they think that it actually gains access to the CNS system, and this can be via the epithelium of the choroplexus. It could reach the brain parenchyma by the cerebral corpora endothelium, and some authors even say that there could be retrograde extension from the oropharynx. Due to these mechanisms, it most commonly presents as the meningoencephalitis, but you can also get a cerebritis rhomboencephalitis, and then usually it's been reported that hydrocephalus and intracranial hemorrhage is very, very rare, and that 10 to 15% and 3% is actually a percentage of the 5 to 10% of all cases. In CSF findings, they say that the CSF can actually usually be normal, but you can get a mildly elevated protein and lymphocytic predominant pleocytosis. So neurolisteriosis has a very high mortality rate, up to 30%, and is also a very high associated with comorbidities, morbidity rate, with patients having neurological symptoms up to 3 months after they're presenting, up to 40%. So there's a number of reasons why this is. Firstly, it doesn't always present typically, and so there's a delay in diagnosis and treatment, and so this leads to the high mortality rate. So someone will come in with symptoms of a meningitis, and usually we would start a cephalosporin, but this doesn't actually cover listeria. Also, when you do the CSF, up to 50% of cases of the Neurolisteriosis will have a negative culture on the CSF. And this could be because there's a low number of bacteria within the CSF, low volumes of CSF sent, and whether the patient has received previous treatments and is now partially treated. Also, you can get encephalitis and rhomboencephalitis and brain abscesses without any meningitic symptoms. And again, this leads to the delay in diagnosis, and this is because listeria can cross the blood-brain barrier. So real-time PCR, which has been recently developed, actually helps a lot with the detection. But like I said, we got our result 1 month later, and it didn't really help. We had to go clinically and radiologically. So these are just 2 trials that I found. So there's a lot of there's a lot of case reports that have been done on neurolisteriosis, but not a lot of real research. And this was the first prospective cohort that was done. It was done in France, and 818 patients with listeria, and they basically analyzed them. It was not just neurolisteriosis, but all kinds of listeria. So the Mona Lisa trial looked at these patients. And I think the key main features that came out of it for me was, firstly, they identified other risk factors for these patients. Secondly, they said that in patients with neurolisteriosis, actually giving them adjunctive dexamethasone, which is a common practice, can actually lead to increased morbidity and mortality. So that's highly suggested that you don't do that. And also it was just found that the correlation between the positive blood culture is actually related to a higher mortality. The second trial came about as a consequence of the first one. Because Mona Lisa hadn't really looked at neuroradiological features, this trial only looked at the radiological features. And what they found is, while there are a lot of studies that actually say rhomboencephalitis, abscesses, meningeal enhancements, and hydrocephalus, as well as even ischemia, may be the presenting symptoms of neurolisteriosis, that when they actually present with cerebral hemorrhages, much more common than what is reported. However, what wasn't taken into account in the study, I think, is whether these patients had any underlying coagulopathies which may predispose them to having intracerebral hemorrhages. And so what they reported was basically that only 3% of their patients had actually presented in the typical way, or what we usually associate with neurolisteriosis, which is rhomboencephalitis, and that up to 64% of their cases presented with intracerebral hemorrhages. But I think, like Kate pointed out, and it's something that I went back and read into, you weren't looking at underlying comorbidities with the patients that could have predisposed to this. So I think the learning points from this case is that always be cognizant of listeria. Intracranial hemorrhages in neurolisteriosis occurs more often than anticipated according to that study. And like here, it is very rare. It's the first case that I saw. And just to have an eye index of suspicion, especially when it's not really tying up and all the not really looking as a typical diagnosis, such as this man who was labeled as a hypertensive ped, as delayed treatment holds a poor prognosis. And luckily for him, he did do quite well. Thank you.
Thanks very much, Aayesha. Lovely presentation of an interesting case, and thank you for allowing us to co-manage with you. Really, or at least to see the patient, very much appreciated. So, can I ask one of the neurology consultants, whoever was mainly involved in the case, was it? I think Susanna, were you involved? Or whoever it was, maybe to give comment, or whoever would like to.
Thanks, Mark. It was actually me.
Oh, apologies.
No. Obviously we talked about it with Susanna. But I think, yeah, I think I've just probably said it all. I mean, we have a patient with an atypical example of radiology in a very unusual presentation of this area. So in other words, you know, it usually presents as a meningitis. I mean, it's way behind the other two causes, and I'm saying that the IB people know, of course. And then if it's not presenting as a meningitis, it's presented as a wrong meningitis, and then it should present with abscesses. And this man presented with hemorrhages. They were clear hemorrhages, but they were atypical hemorrhages. We immediately looked at those images and said, no, this doesn't look right, even though he was hypertensive. It does, you know, there's too much edema, and the distribution was wrong. And then, of course, he turned out to have a fever, and the blood culture sorted it out for us. But an extremely unusual, but recognized radiological picture for neuro and this area. Yeah. And he's done well.
Yeah, no, thanks very much, Lawrence. I mean, how many cases of neurolisteriosis do you guys see per year?
Yeah, I mean, it's 1 or 2 at most. In fact, I think it's less than that. So 1 every, you know, we might see 1 year, and then 1 2 years may go by. But in this literally, it's like that. Yeah, of course, when we have the little run and a year or 2 back, we might see more than 1 year. But I just remember a handful.
So did we see any presentations like this during the Great Poloni extravaganza?
Yeah, so that's what I was saying. So during that extravaganza, we saw more. We had a little, we had a few, but then again, it was a handful of them. Yeah.
But did any of them present in with the same neuroradiology?
Well, yeah, they all the ones that we saw presented with the rhomboencephalitis, but not with the hemorrhage. So in other words, and this was obviously this particular patient was complicated because he was deaf, and you know there were issues already that could be possibly interpreted as brain stem. But yeah, so the ones we've seen have been brain stem symptoms presented, you know, presenting as a brain stem syndrome. But usually more subacute, you know, obviously not an acute presentation. And tiny birds also seen a few, you know, and yeah.
So maybe I could ask I mean, if anybody would like to make a comment or say, could you raise hands? It'd be fantastic. Maybe I can ask our microbiology colleagues. I mean, in terms of the Listeria PCR, sorry, I should have picked this up, but is that only available at NICD? Is it something that we should have? Should it be, is it part of our a panel that we're looking at? Perhaps one of our colleagues, Adrian, you have your hand up.
Hello, Mark. Hello, everybody. The multiplex PCR, which we recently introduced in January, which we shared with you the results. Ruan is not on the call. He's writing his Viro final. Does not include the Listeria in the multiplex, Mark. It's got the more common bacterial pathogens. So unfortunately, even in the Western Cape and private, there isn't a Listeria one that we can quickly send a patient across or a sample and get a real-time result. It's the old problem with the turnaround time towards the NICD. I mean, if there would be, a lot more cases, it might be worthwhile to include it in multiplex, but from a cost containment point of view, we need to focus on the common ones. Unfortunately.
But the presentation of meningitis in risk groups for Listeria is not uncommon. So maybe we should be doing a little bit more, even if part of a study, just to see whether we, you know, what our prevalence really is. I mean, granted, they should probably do worse on you know, ceftriaxone, which they usually would be on. But maybe we could, maybe that could be looked at. So Di
says it is in the panel. I wasn't aware of that. I didn't know we had a positive one before.
Yeah,
apology.
I was just looking through at the positives this week, and I was surprised to see we had Listeria was one of the isolates that we had. I don't know anything about this, the patient though.
Okay, interesting. Thanks. Could you, if you are going to make a comment, it'd be fantastic to see you. So, Sean, I don't know if you wanted to make a comment. You're unmuted.
A quick one. I also thought it was in the panel, and it's part of the reason why I like to ask for it. So I'm surprised to hear that it isn't. But I have a question about the clinical case, if I can.
Please.
So I joined a bit late because I'm on COVID duty, but you mentioned that the patient didn't get antibiotics, but presented with some neurological manifestations and a fever. I'm quite surprised by that. You know, it takes a lot less than a fever and neurology to get antibiotics in casualty. Is that really what happened?
No, he had been started on ceftriaxone.
Okay.
Yes, but it wasn't on presentation. They didn't pick up the beat on presentation. I think it was a day after while he was in the ward.
I think, Aayesha, if I remember rightly, he was on not only on ampicillin, but on gentamicin as well, once we knew.
Yes, so they started that once we suggested it was, once the blood culture came back as positive, they started ampicillin and gentamicin. And then he came down to our ward and we stopped the gentamicin as suggested by IG.
Yeah. Okay. Graham, you got your hand up.
Yeah, thanks for the presentation. Just a quick practical question for the neurologists. Just interested in how one makes the decision around the safety of the lumbar puncture in a patient like this, where there is edema in the posterior fossa. Where, you know, clearly the decision was taken, it was safe, but how one makes that decision.
Yeah, thanks. Thanks, Graham. I mean, I'm actually driving a call on this. And we won't call up the images again, but you know, one looks at the foramen magnum, and I mean, saying obvious things, and looks to see what the potential risks are, any evidence of obstruction anywhere. But if there seems to be, there can be a bit of edema, and the lumbar puncture can be done. So it's let's put it up again, Aayesha. Maybe roll it up from the bottom. So go down again to the, so if we go up, so there's space around there. Now I was looking for the tonsil a little bit up. And everywhere there, as one's going up, we're still hitting the foramen magnum there. Okay, sorry, one down again. So there you want to look, you can see the tonsils at the bottom emerging, and there seems to be space. Okay. And if we go up a bit further, so that's probably where the edema is the worst. The fourth ventricle does look slightly compromised, but it's open, and then a bit higher. Fourth ventricle you can see quite clearly. Okay, a bit higher again. And of course, so there is a bit of compromise around the pons there, but a little bit higher again. But there's space. No, it's a good question. I mean, even then midbrain looks okay. So one would agonize a bit and decide what the benefits and risks are. I mean, it is unusual to get I mean, it's very unusual in a scan like this that the lumbar puncture will cause coning. So just going through it like that, I would be happy to do a lumbar puncture that particular patient.
Okay, no, thanks, Lawrence. That's useful.
Thanks, Graham. Goa?
Hi, Prof. Just from micro side, our multiplex panel does have Listeria monocytogenes. It also includes strep pneumonia, Haemophilus, and then also group B strep.
Thanks for the clarification.